The first case is an 81-year-old female with a past medical history of hypertension. She was admitted in December this year with obstructive jaundice and weight loss and presented with deranged liver functions on admission. So the ERCP performed in December showed fish mouth appearance to native papilla with drainage of mucoid material with no bowel drainage. There is grossly dilated pancreatic duct with amorphous intraductal material, and also failed CBD cannulation. The subsequent CT in the same month showed 6 cm pancreatic head mass with dilated pancreatic duct, tumor density in pancreatic duct, non-occlusive main portal vein thrombosis, and multiple liver metastases. Her latest bilirubin is around 400. So these are the ERCP images and the CT images. So EUS-guided biliary drainage will be performed today. Be performed by Professor Shannon Chan, and Professor Moon and Dr. Marc Wong will be our commentators.
So good morning, welcome to Day 2 Hong Kong Live. So with me together is supervising the procedure is Professor Moon, and also Marc here, and also our HPP surgeons Eugene and our GI colleague Jackie, and also with our team of very expert nurses. So I'm sure you've heard the history, an inoperable pancreatic head tumor with biliary obstruction. So in general, for say head of pancreas with biliary obstruction, failed ERCP, we can consider several options of biliary drainage. So either a CDS or an HGS procedure. So in general, if a CDS procedure can be performed, it seems to be a safer procedure. So I usually would go down to the duodenum and check if it's feasible. But actually already on CT scan, I saw that the tumor is quite bulky. So there might not be any landing zone for CDS procedure, but I'll check anyway. So I'm pushing the scope through to the pylorus.
Especially if the patient have pancreatic cancer with duodenal obstruction, maybe HGS can be better than CDS because of the food impaction through CDS stent.
So you see here, this is the huge pancreatic tumor right here, together with, so you just screen down to the duodenum. You see there's a tinge bit of ascites outside, but a very small amount. So if you trace along to find the CBD, actually this is the common bile duct. So because the patient has portal vein thrombosis, we expect a lot of varices around. And as you can see here, there's quite a lot of blood vessels around. And actually, the CBD was pushed away by the tumor. So the CDS procedure would not be an easy one. So then I would go on to see if an HGS procedure is feasible.
I think in the D1, the window for puncture is minimal. Yeah. And the axis is very distorted.
So then now I pull back the scope to the OG junction. And you can see here quite dilated ducts. So this is a portal hilum. So if you do a left talk, you will see the segment 3 does gradually coming out. So the segment 3 does usually, I would find the portal hilum and then trace. And the movement is usually a left talk and push the scope a little bit down. And you will be able to trace the left duct.
Now Shannon is doing very well. There is, we can approach B3 or B2. For the antegrade stenting, B2 can be selected, but for the direct HGS, usually B3 can be selected. So now Shannon is doing very well. Now we can find the B3 dilated segment.
So in general, for B2, it is nearer the OG junction. And if you do an HGS at that region, there is a high risk of mediastinitis. So unless you're doing an antegrade stent, as Professor Moon have said, or a rendezvous technique with just a guide wire insertion is usually okay. But if you need to dilate the tract to put a metal stent, there is a slightly higher chance of mediastinitis. So if given the choice to do an HGS procedure, try to find the B3 ducts. So you see here the B3 ducts is very nicely seen. And then we need to look at the vessels. So this patient has a portal vein thrombosis. So you see that it's quite vascular. And this is a very frail, thin patient. So you can see that the liver, parenchyma, there's actually not a lot of cushioning. So to decide where to do the procedure, you see that the duct is very dilated. So you can either puncture here, but the liver cushion is actually minimal, which is a little bit unsafe. So if you trace more to the medial, the cushioning is more. But also try to avoid being too close to the portal hilum because you don't want the stent to be sitting at the hilum. So here you see that I think this segment here is quite feasible. So then we need to look at the vasculature to make sure that we don't hit them. So let me see. So maybe this is a good site for puncture. What do you think?
Yes, I agree.
Okay.
As I mentioned by Shannon, we need some distance from the stomach and dilated bile duct to make cushioning. One reason is to reducing biliary leakage, and another one is much decrease the stent migration.
Let's measure.
Professor Moon, usually what would be the ideal minimal distance of liver parenchyma?
At least
do you
2
prefer?
centimeter and 3 centimeter.
So I guess I'll just have to go a bit flatter so then we get more tissue cushioning. So the maximum we can get is just around 10 millimeters. So I guess another trick is if you don't have enough liver parenchyma, then you just have to insert your uncovered portion deeper in so then it's more secure. So the stent we've chosen for today is hot geoball. So it's not available in the market yet. We're now running a cohort feasibility study for this stent. Basically, it's like a geoball stent. So can you zoom close to the stent? So basically, it's like a geoball stent, but it's cautery fitted. So you do not need to go through cystotome. So needle, guide wire, and then you can change to this hot geoball stent. And the new thing about this stent is that the uncovered portion, I'm not sure if you will see it now, but the uncovered portion you'll see later. There is, X-ray. So you see there is a black line right between the two black dots is where the uncovered portion is. And you can see two black lines that is crossing between the two black dots. So it's very clear where the uncovered portion is. So of course you want the uncovered portion to be entirely in the dots and give a little bit of landing zone, so maybe a little bit more of a covered portion in the dots, and then we can deploy the rest of the stent in channel.
This stent is 1/3 uncovered portion on proximal biliary part, and it has a radiopaque marker, new one. And another 2/3 is covered. And uncovered portion should be inside the intrabiliary tree, and covered portion should be on gastric side. And it's a most technical advantages using hot delivery system, even HGS stent. So we can reducing one step for tract dilatation using that kind of electrocautery delivery system.
So I'm trying hard to avoid that vessel right in front of the duct. I think this might be a good spot. I'm going.
Now Shannon using Olympus EasyShot 3 19 gauge needle. It's very nice, very flexible, and very high functionality. success?
So now I've punctured the dot, and there is a recent Japanese study that is, and it's actually white bile. As you can see, the bilirubin is up to 400. It's actually white bile coming out. So studies have, a recent Japanese study have shown that during XGS, if you're able to aspirate at least 10 mils of bile before you do the procedure, it significantly decreases the post-HGS sepsis. And I guess because the ducts are chronically obstructed and dilated, so bile for culture. So injecting more contrast without decompressing it would increase the rate of sepsis.
Now
So
B3 is nicely punctured and installing contrast media. You can see the whole bile duct from the left side to right side.
Don't capture, I'm going. So now we can fit the guide wire in.
Now what kind of guide wire do you use?
Oh, my favorite all-time guide wire is a curved tip, angle tip VisiGlide 0.025.
Very nicely punctured.
So it is essential that the nurses hold the scope because it's best to keep, when you do these procedures, to keep the guide wire in view. So always the guide wire and the needle should be in the view of the US. So now I'm trying to manipulate the guide wire down.
Yourself. You are doing operator and assistant simultaneously.
Usually I try to do it myself, but if I can't, then Marc is a very expert guide wire and assistant, as you can see from yesterday Raymond's rendezvous wire. So you see that my guide wasn't able to go through to the distal dot, so I either can loop in the bile dot or I can try to go to the right dot so that my wire is more secure. So I'm trying to go to the right side, which might be a little bit
So
difficult.
your assistant looks very comfortable because he doesn't handle the guide wire, just
okay.
holding it.
Please.
Oh, you asked to you another
Okay.
doctor.
Because
Very nice team, very collaborating.
Marc is very good at these guide wire manipulation. So as mentioned, teamwork is very important. And so I'm a surgeon, and Marc is a GI gastroenterologist. So in our hospital, the surgeons and the GI team work very closely together.
So you want to go to the right duct?
Try. If I can't,
It's another
then,
option to right side, deep portion, either way.
so if
just
I
for
can't, then maybe
HGS?
just loop for the. So of course, at this point, if we are able to get the guide wire down to the duodenum, we can consider antegrade stenting, or we can do HGS. But I guess for this patient, such a bulky tumor, first, I think that the chances that the guide wire would get through the duodenum is very low. And second, if we do an antegrade stent, it probably will obstruct very quickly. So not a good idea.
As you can see, Marc's hands, he is controlling very nicely, rolling and pushing. The kinds of high performance guide wire can be make very important functions.
So Shannon did a really good puncture that the guide wire can manage to go quite far, and we want more leeway. So I'm going to make some loop. Ideally, yeah, we do want, if we go to the right duct, and it'll be really good. But now we do have enough space to work.
Okay, I'm okay. Oh, so now we will exchange. So during the exchange, it is also important to keep the guide wire in sight. So you see here, the guide wire is right here. Oh, okay, I'm gone. So you see here, the guide wire is always in situ in the EUS view.
So more deeper insertion of guide wire is better. So, and want to keep in mind the pushing the guide wire is important because sometimes the guide wire can be looping stomach and gastric wall side. So co-work with assistant and operator is very important. As you can see on fluoroscopy, now the tip of echo endoscope is facing
哦，開住啊！
center of bile duct. It's also very important.
記住俾翻個包袱。
Hi, Shannon. Very nice puncture and also guide wire advancement. Any tips like the minimal length of guide wire in the duct that you can do the HGS?
I don't really think so. As long as you feel that the wire is stable, it's okay.
Longer is better.
Of course, the safest one is your guide wire can go through the duodenum and loop at the duodenum. Then you have the most stable platform.
Now Shannon is directly inserting the stents with the electrocautery delivery system over guide wire.
So the setting we will use is the same as hot axial setting. So 120 watts of pure cut mode.
It may be the first live demonstration using that kind of hot delivery system HGS stent.
Oh, don't give me so much pressure.
Cheers.
Okay, so now.
And during US view, the wire always in view, very important.
Now guide wire is much better.
Wire 要收少少喎，唔該。
收多少少。
wire 可能要收多少少。Somehow I wasn't able to push the stand out for some reason.
So now there are many options for HGS stent. Number one is a plastic stent. Dr. Itoi from Japan is developed for nice plastic stent having a long pigtail. Another one is a metal stent. Now Geovstent Tail Medical is the most classic stent. And it's 1/3 is uncovered, 2/3 is covered. And very recently, our group developed a new stent, a special MG having large anchoring proximal flange. Yesterday, I did a speech about that. It has a 20 millimeter of proximal large flange to completely folding back. So it can reduce migration of the stent inward or outside. And another new stent from Korea and the Japanese studies group studied and direct puncturing with a thin delivery system without any electrocautery dilatation. So now a little bit resistance to inserting the stent.
I don't know why, because it seems that there is, as you can see on the X-ray,
Yeah.
the stent is still maybe like 3 centimeters away from the
So
channel.
maybe it has an electrocautery function, the stent. Maybe the tip of stent a little bit harder or stiffer than other stent. How about,
I've used it before, and I don't think that was a problem.
could you
at that
change
time.
the stent with different one? Do you have any different one?
So if we only have one.
Or you could check with the conventional electrocautery dilatation and then try again.
So I'm not sure if you see on the scope that there seems to be. I'm not sure if there's something inside the channel. So at this point, you see that there is some.
Yes,
Some-
almost
something
nearby
there,
the
yeah,
level
yeah.
of the
diaphragm.
So I don't know. Did we use this scope yesterday? I really can't go
Just take it
through.
out and try.
So I'll.
Now,
Take it out first.
So I'll just put the my scope back to a good view. Make sure that my guide wire is stable, and then I'll exchange the stand out to see what happened. So I'll exchange the stand out for the time
We
being.
can see the guide wire safely on the
Yes,
screen.
yes. So I think this way is better.
This one. Yeah.
So by all means, keeping the wire access is always safe.
Exchanging.
Yeah, so I'm exchanging.
Yes. Do you have another same stand or?
I don't think there's a problem with the stand, however.
Okay. How about checking with?
So another
Dialogue
option, we have another stand called the Spexus head type stand. But that is not core tree fitted, so you have to use the 6 French cystotome, and then to use the Spexus head type stand. So let's use the cystotome first to see if the cystotome can go through.
See, guide wire nicely seen on EOS image. It's very important. Now Shannon is doing very well to keep the scope position safely, even exchanging the kind of stand.
So let's see if it is smooth first, because even if I dilate the tract and I can't get the stent through, then it's still difficult. 我有條 Spexus M type 喺後邊。
Professor Moon, I think one challenge for doing HGS is usually involve a lot of exchange of instrument.
Yes, it's true, actually.
And in the stomach, sometimes holding the scope position can be difficult.
Yeah. Now here, local expertise is doing very well about co-work. What kind of system do you use?
So this is a 6 French cystotome, which is our usually go-to option.
From Taewoong Medical or Wallflex?
It's from
Wallflex.
Wallflex.
So Shannon is trying to introduce the cystotome through, and also very importantly, the tactile feeling of the introduction of the instrument through the
Cystotome
channel.
went through very well.
Yeah.
Okay.
Now you can see the radio opaque marker of cystotome.
Okay, so please, it's okay, can I hold this? Okay, so the guide wire is here. Can you hold the scope? Okay, so we're going through. Okay. Have you connected it to energy? Okay. Okay, very good. So here. So it seems a little bit difficult to go through. So can we check the energy, every machine? What did? Okay. So in case where the cystotome fails, then we can use a balloon dilator.
So usually we would look at the movement of the cystosome under both fluoroscopy and also supposedly you can also see that in the US view.
Okay, so let's try. So after a bit of struggle, I decided to try to insert the hot geoball again. So I was able to insert it. So you can see on the X-ray that the hot geoball stand is right at the gastric wall. So just now it might be because that the scope angulation was too straight. So I straightened up the scope a little bit and tried to push, and it was able to go through. This is a hot geoball stand, so we do not need to dilate the tract. So now I'm going to step on the energy device. So So it seems the pushing out the stent is still a bit of a struggle though. Oh. So I'll pull back the stent and try. So I still think the channel is not very.
I see the direction of the stent insertion is already very strict, so supposedly very conductive to securing the biliary access.
So it's still a bit of struggle to get through the stent.
Very strange. It's always
Yeah,
happened
it's
to
very
the
strange.
live demonstration. Very
So-
different with routine clinical practice.
So again, it's always important to find your guide wire. Okay, so it still couldn't go through. Ooh. Okay. So maybe we'll try to pull the stand back. So keep the wire, please. Because I somehow feel saying it's a bit of more struggle than normal to push the stand out. Strange.
So usually in this situation, I see Shannon is trying to do a couple of things. The scope angulation is trying to be kept minimum, and also there's no locking of the dials. So supposedly would help the insertion and manipulation of the instrument inside the channel.
I think rotating the scope to see, rotating the X-ray to see the orientation of the stent is also helpful.
Not yet.
So I can't get the stent out from the channel. So it's a little bit strange. So I think we should try to change the scope because the channel is quite blocked. So can we get another linear scope? Sorry, so maybe I think we need to, I'll keep the wire and I'll exchange to another scope and try to repuncture because I don't think this is very safe to proceed and the channel seems very stuck. So what we did was we changed the scope because I felt that the distal end of the scope where the channel was not very smooth. So I kept the wire in situ and then we actually feed the stent into the new scope before we inserted the scope. And we also added some lubricant at the stent to make sure that it's easy to pass. And so we exchanged kind of a little bit like a rendezvous maneuver where we had the wire in the stent and then through the channel. And so now we are back in our position. And so in order to avoid a disappointment, again, we have already actually, this is the stent. So we have actually burned the tract with the hot gel ball and it went through already. So it's good to turn the corner and be 100% safe. So while we insert the stent, Billy, as our very experienced assistant, is trying to retract the wire. So now you see on the screen, the two black dots is where the uncovered stent portion is. So this stent is the same as the ERCP biliary stent. So when it deploys, it tends to go in. So the endoscopist would have to pull back the sheath while the deployment happens. So it's a coordination between the nurses and the endoscopist. So this uncovered portion has to be completely inside the bile duct. So I
Very
think
nice.
this is so do you think it's a good position?
Yeah, a little bit retraction is also good.
Yeah, so we can deploy first.
After deployment, you can adjust the position.
Deploy.
Now proximal tip is almost bifurcation.
So now the stent is being deployed. So the initial step is also always slow. So now you see the stent is moving. So we can deploy the entire uncovered portion first. So we deploy until the black mark.
Again, radiopaque marker is uncovered portion.
Yeah. So now the uncovered, so a bit more. So here. So now the uncovered portion is fully deployed. So I usually would then reposition the stent right now, because if initially we pull back too much, there's a chance of dislodging. So now I can pull back my stent a little bit. Okay, I think this is a good position. So we can continue deploy.
Can we also have the endoscopic view for room 1, please?
So continue. 等等啊，Billy，等等啊。其實唔使嘅，so we don't need the endoscopic view for now.
So
We need
now
it for
usually
later.
we are doing intra-channel,
Yes.
intra-walking channel
So,
deployment and
continue
then
to-
showing endoscopic view.
Yes, sure.
So we continue to deploy.
The length of this stent is a 10 cm.
Yeah, so this is, okay, so stop.
So
this-
ideally, intragastric segment is 3 cm.
So for now, the X-ray is this, you keep this X-ray position, and for the rest of the stent, we will deploy in channel. So it's important to keep the X-ray in view. So while the stent is being deployed in channel, the stent position on X-ray should be static, so it should not move at all. So we can continue to deploy the stent.
Because
So-
the scope is still right at the gastric wall, so supposedly at this juncture, we still do not need the endoscopic view.
That point is very, very important to make a straight
Okay, so now
without
the stent
no
is fully
space
open.
liver and gastric wall.
Okay, so now we need the luminal view. So you see now that the X-ray, the stent is quite nicely deployed. So I usually would keep this view, and I do a right top. So you see on the luminal view that the stent it's on the left-hand corner. So you see here vaguely, you see here at the 11 o'clock region. So this is when I would change to a luminal view. So now that the stent is fully deployed, I just need to push out the stent. So you see here it's pushed out. So my practice
Very
is
nice.
I try to pull it into the esophagus. So I'll pull back the scope a little, push the stent out a little, pull back a little, push the stent out a little, and push it out a little, so until you see the end of the stent. So the reason I like to pull it into the esophagus is because in case you need further manipulation, the stent position is straight. So if you deploy it entirely in the stomach, then going back in would be relatively difficult. Having, so
Very
now
nice.
this is the end of the stent. So you see bowel coming out.
Yes, very nice.
And the stent is in good position. So sometimes if you are worried that your uncovered portion, you're not sure whether it's completely in the bowel duct, you can insert a ball tip at this point and inject contrast just to make sure that there is no bowel leak. But I think this stent is quite nicely deployed, so I don't think we need it. So thank you. This is end of the demonstration of an HGS. So I think this is a good case to demonstrate because usually on live demo, the HGS are very smooth, it looks very simple, but actually in real life, all these things do happen. So it's not the first time for me that the cystotome didn't go through and the energy just doesn't burn through, but you just need to have a bag of tools and options that you can go for. So unluckily in Hong Kong we don't have the ES dilator. So in Japan they have the ES dilator. So in case the cautery doesn't go through, then you can still use a non-cautery dilatation. So for me, if the cystotome doesn't go through and this hot gel ball doesn't go through, then I would change to a 4 mm hurricane balloon and try to dilate the tract and then insert another stent. So thank you.